All right, let's get straight to it. Primary and secondary immunodeficiencies. This is a hyperdense, high-yield algorithmic explainer specifically targeting a perfect 270 plus on your step 2 CK. We are completely skipping the introductory fluff today. Instead, we're focusing entirely on distinct biochemical mechanisms, pathognomonic diagnostic cutoffs, and strict differentiation rules. Here's the clinical algorithmic tree. To master immunodeficiencies, you literally have to divide these defects strictly by cellular line: B cell, T cell, and combined. And finally, phagocytic and complement disorders. Section 1. B cell humoral deficiencies. We're isolating the failure to produce protective immunoglobulins. Let's start with X-linked agammaglobulinemia, also known as Bruton's. So what's the fundamental mechanism here? It's an X-linked mutation in the BTK gene, which specifically encodes a tyrosine kinase. This mutation abruptly halts B-cell maturation right at the source. The end result? A complete lack of functioning B lymphocytes and severe hypogammaglobulinemia. You'll typically see this present in male infants around 6 months of age, which makes perfect sense because that's exactly when maternal IgG wanes. Now, the absolutely crucial thing to look for is the pathognomonic physical exam finding. Because there's an X-linked arrest of B-cell maturation, these patients will present with a profound absence of tonsils and a complete lack of palpable lymph nodes. Think about it. The physical tissue architecture simply cannot develop without those missing B-cells. If you see absent tonsils in a vignette alongside recurrent encapsulated bacteria, lock in Bruton's. Moving down the B-cell algorithm, you need to lock in this absolute diagnostic cutoff, an IgA level of strictly under 10 milligrams per deciliter. This is the exact biochemical marker for selective IgA deficiency, which happens to be the most common primary antibody deficiency. With selective IgA deficiency, you've really got to map out the clinical triad. First, suspected in patients dealing with recurrent mucosal infections, specifically Giardia lamblia in the GI tract. Second, recognize its incredibly strong association with autoimmune disorders, particularly celiac disease. And third, and this is vital, be hypervigilant for a lethal board trap. These patients can form anti-IgA, IgE antibodies. If you give them a blood transfusion or standard IVIG that contains even trace amounts of IgA, it triggers immediate fatal anaphylaxis. Okay, now you have to differentiate common variable immunodeficiency, or CVID, from Bruton's to avoid a classic demographic trap. CVID features totally normal B-cell counts, but the plasma cell differentiation is defective. Bruton's, on the other hand, has completely absent B-cells. Furthermore, CVID typically presents much later in life, often the 2nd to 4th decade, so between ages 15 and 35. Bruton's presents in infancy. Do not mix these up. Take a look at this matrix. It perfectly illustrates the exact quantitative immunoglobulin drops you have to memorize. Notice how CVID involves drops in IgG, IgA, and sometimes IgM, despite normal B-cell numbers. Meanwhile, Bruton's shows uniformly low titers across all classes. Visualizing this pattern is absolutely mandatory for test day. Section 2, T-cell and combined deficiencies. This is where the immune system completely loses its targeted defense coordination. Let's see how this builds the catch-22 phenotype for DiGeorge syndrome. This is caused by a 22q11.2 microdeletion affecting the 3rd and 4th pharyngeal pouches. The phenotype is anchored by thymic aplasia, leading to T-cell deficiency, contratruncal cardiac defects like truncus arteriosus, and critically, hypocalcemia secondary to parathyroid hypoplasia. That hypocalcemia is incredibly high yield. It frequently presents as neonatal tetany or seizures. Next up is the ultimate pediatric emergency, severe combined immunodeficiency, or SCID. You have to differentiate the underlying defects here. Is it an X-linked IL-2 receptor defect, or is it an autosomal recessive adenosine deaminase, or ADA deficiency? Regardless of the specific cause, it results in a profound, complete lack of T cells and an absent thymic shadow on a chest radiograph. These infants will present with failure to thrive and severe opportunistic infections like PCP. This requires immediate protective isolation and definitive treatment with hematopoietic stem cell transplantation. For Wiskott-Aldrich syndrome, you want to map the WASP gene defect directly to its classic presentation. This X-linked recessive disorder impairs actin cytoskeleton rearrangement. Just memorize the exact triad using the mnemonic WIPE. Wiskott-Aldrich, infections with encapsulated organisms, purpura due to profound thrombocytopenia, and eczema. Rounding out our combined defects is hyper-IgM syndrome. The biochemical mechanism here is an absence of the CD40 ligand on T cells. Because CD40L is required to signal B cells to undergo class switching, the immune system is essentially paralyzed in its default state. This inability to class switch leaves IgM elevated or normal while completely depleting IgG and IgA. Section 3. Phagocytic and complement disorders. We are now looking at chemotaxis, respiratory bursts, and the complement cascade. Anchor chronic granulomatous disease directly to its distinct biochemical failure, a defect in NADPH oxidase. This completely abolishes the oxidative burst, leaving patients highly vulnerable to catalase-positive organisms, think Staphylococcus aureus and Aspergillus. These organisms literally destroy the host's residual hydrogen peroxide. The absolute diagnostic standard you must look for in a vignette is an abnormal dihydrorhodamine or DHR flow cytometry test. Listen closely to this absolute diagnostic cutoff for leukocyte adhesion deficiency, a delayed umbilical cord separation extending beyond 14 days post-birth. That right there is your massive pathognomonic red flag. To confirm LAD, you must identify the exact mechanism, defective CD18 integrins, which completely ruin phagocyte recruitment from the blood. This creates a brilliant clinical paradox that you'll definitely be tested on. A blood draw will show profound leukocytosis because all those white cells are trapped in the bloodstream, alongside an absolute clinical absence of pus at the sites of severe skin and mucosal infections. Let's tackle the complement cascade. Isolate terminal C5 to C9 deficiency exclusively to an inability to form the membrane attack complex, leading uniquely to recurrent disseminated Neisseria infections. Conversely, lock hereditary angioedema to a C1 esterase inhibitor deficiency, which causes bradykinin excess. The diagnostic key to look for: low C4 levels, life-threatening laryngeal edema, and an absolute lack of urticaria or pruritus. Section 4. High-yield diagnostic traps. Let's run through some rapid-fire board vignettes to really test these rules. Here's trap 1. A 6-month-old boy is brought in with dry, scaly skin, scattered petechiae over his entire body, and recurrent otitis media. His platelet count is critically low at 25,000. So what's the diagnosis? If you mapped the algorithm correctly, that combination of eczema, profound thrombocytopenic petechiae, and recurrent infections immediately points to one strict diagnosis. Deconstructing this explanation perfectly reinforces the rule. It's Wiskott-Aldrich syndrome. This tests your knowledge of the WAS gene mutation on the X chromosome and its direct result, impaired actin cytoskeleton rearrangement during interactions between T lymphocytes, antigen-presenting cells, and B lymphocytes. Let's look at trap 2. You have a patient explicitly diagnosed with selective IgA deficiency. Their lab profile confirms IgA is less than 7 milligrams per deciliter, with totally normal IgG and IgM. The question asks for the most appropriate next step in management for their immune status. What intervention do you choose? Dissecting the reasoning here confirms a massive high-yield trap. The correct answer is that absolutely no intervention is indicated. Selective IgA deficiency treatment is directed solely at symptomatic infections. Giving prophylactic IVIG is completely wrong and highly dangerous due to that lethal anti-IgA anaphylaxis trap we discussed earlier. Asymptomatic patients require zero specific monitoring. We'll conclude with our final trap. A patient presents with sudden, life-threatening laryngeal edema, drastically low C4 levels, and zero urticaria. You know this is hereditary angioedema, so why is treating this patient with epinephrine or antihistamines a fatal board trap? Because this edema is mediated by an excess of bradykinin, not histamine or IgE. Epinephrine will do absolutely nothing. You must treat with C1 inhibitor concentrate or a bradykinin receptor antagonist. But here's a final thought to test your mastery. If a patient presents with angioedema, but they do have urticaria, what entirely different immune pathway just bypassed everything we discussed today? Master these cutoffs, understand the why behind them, and you will absolutely dominate the boards.